which we used to call NHIF, the National Hospital Insurance Fund.
Yes.
First and foremost, we have 4 acts. We have the Social Health Insurance Act of 2023. We have the Digital Health Act. We have the Facility Improvement Fund Act of 2023 equally, and the Primary Care Act. But let me concentrate more on the Social Health Insurance Act.
Yes.
The changes that are there, one, we have 3 funds that have been introduced, as opposed with what we used to have, just a card where people used to pay 500 shillings, and that is the only fund that used to be there. So we have 3 funds. One is called the Primary Care Fund, which is inside the Social Health Insurance. The Primary Care Fund is basically to take care of the local health facilities, what we call the dispensaries, the health centers, take care of them, because the level 2 and 3, 1, 2, and 3, people will not be paying the 20 bobs that they used to pay, the 50 bob they used to pay, they will no longer pay. It is publicly funded, and we shall, everybody is going to access these facilities without paying a dime. Then you move to the Social Health Insurance Fund, which is now, we are calling the NHIF. We used to call the NHIF.
Yes.
In the Social Health Insurance, we will be paying 300 shillings, a minimum of 300 shillings. And no, somebody like me who is salaried per my household, then I will have to pay 2.75 of my gross salary. And this will help to also cater for other people who are not able to pay for themselves, probably even in my own family. Right now, if you look at the number of WhatsApp groups that we have, because somebody wants to go to India, another person wants to do an operation. So this social health card will be open for all at 300 shillings. And you may want to ask, what about the person who cannot afford the 300 shillings? Because we have them in our society. We already have a testing tool which will be used to actually tell whether you can afford 300 or you may not afford 300. If you cannot afford 300, then the government will pay for you.
Okay.
The indigents and vulnerable groups will be paid for by the government. Then we move to something else very interesting. Right now, what is happening with NHIF is you go to hospital, registration is maybe 1,000 shillings, and we get it from the card. By the time you're done with the registration, your card is depleted and you cannot access the services. So you're forced to go out, buy yourself drugs, or maybe even get other services from outside the health facility. But what we are saying is we have another fund of emergency, critical illness, and chronic illness. If you look at some of our facilities, they are near a road, and with the many borders that we have, there are so many accidents that happen, and it's an emergency. And sometimes you're taken to the health facility that is near there, and you're told you do not have either your NHIF card or you do not have something, you know. Therefore, with the emergency fund and critical illness, then you will be able to be treated. And the health facility can claim later that we treated this person, it was an emergency, and this is the kind of emergency. Again, issues dialysis. So many people, it's expensive.
Very expensive.
So you deplete your per session. Issues cancer, very expensive. So you deplete your social health card, then we can plow into the fund, the kitty, which is for chronic illness, emergencies, and critical illness, and this person will be treated. Therefore, issues of WhatsApp groups will be an issue of the past, because everybody is going to be covered in the country. And just like I said, what we want in this country is an accessible, quality healthcare, and available at the same time, and affordability. Accessible in the sense that you can go to any health facility and get treated. people walk for long distances looking for just one service, where else there is a private facility which is just next to your household, or there is a religious-based health facility and it's just next to your household. So what we have done is to do an assessment of all the levels of hospitals in this country, whichever, whether it is public, private, or faith-based, so that we are able to do what we are calling the primary care network, mapping out the type of facilities that are near you. And with the help of community health promoters, you will be able to be directed to the right health facility that you require for whatever service that you want. And this is really going to help us so much. That takes me now to my next point. The other act that we have is the Digital Health Act.
Okay.
And I have said this before in many places, that when I was growing up, my mother had a very special exercise book. And you know, we were many, so she had so many of them tucked in a wardrobe somewhere, you know. And every time you got sick, you had to produce this exercise book. Why are we not doing the interrelatability of data? So that if you are referred from a certain health facility, then whichever other health facility that you go to, you will find your information with the health staff who is going to be serving you. And this interrelatability will help us even in our referral system, right from the grassroots with the community health promoters who are doing very basic roles